Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
This comes down to the fundamental nature of insurance companies as a publicly traded company, right? It is by mandate that their primary responsibility is to their shareholder. So that's a problem. We would call it a conflict of interest in medicine. Somehow it's not for them. I don't know. Everything we talk about when there's a failure of the healthcare system, the person that suffers is the patient. It's never the insurance company. It's really not the physician. We can complain about reimbursement rates. We can complain about staying late in charting, but we don't suffer. Patients suffer.
You're listening to the voice of Dr. Nathan Hammel, a board-certified orthopedic surgeon with fellowship training in orthopedic oncology. He spent 2 decades in medicine, starting in the Navy and moving into private practice, until the systemic dysfunction in healthcare made it too hard to keep doing the complex surgeries he'd trained for years to master. So he stepped back from operating. These days, he does contract utilization review for insurance companies, which means he's the person deciding whether other doctors' surgeries get approved. I've spent my career fighting denials, while he's sat on both sides of that desk. I wanted to hear what it looks like from his vantage point.
My name is Nathan Hammel, and I am an orthopedic surgeon, still practicing at a reduced level. I grew up on the East Coast, and I had a job after college before I went back to medical school. I went to Jefferson Medical College, which at one point was known for having the most practicing graduates of any medical school in the country. Might still be true, might not be. And then I did a military scholarship program for medical school. So I did my residency training in the Navy, and then fellowship training in the civilian sector sponsored by the Navy, and then worked at a teaching hospital in the Navy for 5 years before going out into private practice 8.5 years ago. I've been out of residency for 15 years. And over time, I went from doing musculoskeletal oncology, which is bone and muscle tumor surgery. And then I started to what I've come to understand as de-escalate my life. I eventually stopped doing tumor surgery because I was practicing in a practice environment that I didn't think was conducive to the kind of multi-specialty care that you need to do a good job with tumor surgery. Weekly meetings with radiation oncology and with medical oncology, tumor board meetings with general surgery, easy accessibility to vascular surgery co-surgeons. And then I spent some extra time with my family, and then where people told me I was going to be bored, other things that interest me just automatically filled in the spaces. So I'm a bit of a tinker, and during my practice, I came up with a technical solution to a problem that I had in surgery that wasn't currently available. And with some encouragement over many years, I actually filed the patents. Looks like those are on their way to being granted. I ended up starting a medical device company to kind of back that up, and then finishing up the design of that. And more recently, when I really stepped back and went to a 1/4 full-time equivalent practice, so just 6 days a month of clinical practice, then I had a lot more time, and that's when I really started to make progress on my patent work and my design work for this invention/medical device company. I've also done some administrative medicine, I'll call it, so utilization review, which I think you've discussed before. I do that work on a contract basis for several companies, and I do have a lot of familiarity inside with utilization review. You can have a really expensive procedure, but if it's not commonly requested, it doesn't get any attention. My surgeries cost them a lot because the implants cost a lot and these patients stay in the hospital. So I'll request an expensive surgery 6 times a year, but they get hundreds and hundreds of knee arthroscopy requests every day. And inappropriate use of knee arthroscopy is a way more expensive problem for them than inappropriate use of major resection reconstruction for tumor patients.
Do you have any thoughts on utilization management from the other side of the equation in terms of how it's done for payers, since you've worked in that arena?
I see a lot of denials for surgery. I do appeal reviews, so I see a lot of appeals for denied surgeries where the denial was appropriate based on the information provided, both either not enough information provided or clinical scenario that clearly is in conflict with what the policy plan guidelines have said work for the condition. I've been on the other side. I've had my surgeries denied, surgeries I think were appropriately indicated. I look at it and I say, well, if you're just operating under the plan policy guidelines, this unfortunately is a denied surgery. This person hasn't had an injection, they haven't had physical therapy. And the insurance companies do make the rules. And when we sign up for those insurance plans, they send us the 900-page PDF and none of us read it, but it's in there in writing what you have to do to qualify for these surgeries to be medically necessary. So physicians probably don't have proper training on how to get your surgery approved. And then another argument could be made that they don't have the time to really package up every individual's case to conform to a plan policy guideline. So, a career of being on both sides of utilization review, I resent that it exists, but it's driven by bad physicians doing unnecessary procedures, doing unnecessary surgeries because they're incentivized for unit-based fee-for-service work. So at the end of the day, utilization review is just healthcare rationing to keep the lid on what would be unbridled physician overutilization, because that's how we're financially incentivized to care for people, is to do things to them.
I think that's a little bit of a tough pill to swallow for me because I see it on the other side of the equation, which is I'm in primary care. So if you think about what you do for a living as a surgeon, how many different procedures or codes do you think you bill on an annual basis?
Oh, these days maybe 15. I mean,
Yeah.
used to be 50, now it's 15.
Yeah. I just think that there's a counterpoint to be made, which is that the complexity of the variety of types of services in a field like, for example, primary care, and then multiply it across the number of different payers that you maintain contracts with, not because you want to contract with a million different insurance companies, but because you have to maintain access for your patient population. It's almost virtually impossible to keep track of all of the different requirements and guidelines that are put forth by every single insurance company that may not always be in alignment with one another. And then on top of that, just the variety of procedures that we do or tests that we order,
Yeah.
make it difficult to keep track of what's going to be covered and what's not. And so if there was some way of communicating to the providers at the point of care, hey, you want to order this, here's what's required, that would be helpful, because there's thousands of criteria.
There's a bell curve. I mean, there are well-intentioned physicians that aren't trying to do unnecessary procedures, and that's most, okay? There is a very small subset of physicians that keep coming up. When they close one loophole for insurance billing, they'll exploit another one. They announced overutilization of a skin substitute code. In 2019, it was like
Mhm.
$15 million in skin substitute coding. In 2022, it had jumped to $1 billion, including psychiatrists coding for reimbursement of skin substitute grafting procedures. These people come to our office and they sell us a drop shipping service where they're going to sell these collagen-based dressings, which are designed for complex, non-healing wounds. And they say, you're just going to ship this to these patients with a total knee. It's a post-operative bandage. They're going to change it every day, and it's going to land $5,000 in your practice accounts. I mean, it's very clearly an abuse of the system, an abuse of Medicare, because Medicare, in general, they're starting to, but in general, doesn't require prior authorization. So just time after time, there are these Medicare abuse workarounds, and to try and plug those holes, they come down and they try and regulate access to high volume codes. So this is what I was talking about earlier. If you're trying to say, listen, I'm just trying to get this person a colonoscopy, they say, yeah, but people are ordering hundreds of thousands of colonoscopies a year. When we multiply that out, it's this enormous number. So they go for the high total value. So it's frequency times cost. They try and restrict those things and put a lid on it, because although you're being well intentioned, I've seen the other side. There are people. I mean, this happened. A couple orthopedic surgeons in Texas went to jail for Medicare billing injections that were never done. They were just generating office visits where Medicare patients were receiving injections in the office that were just fraudulent. And so the utilization review industry grows out of abuse of the system. Because it's fee for service, you will have physicians that abuse that because they can just pull the lever like they're at a casino, and then it unduly burdens the rest of us.
While Dr. Hammel is critical of outlier physicians who abuse the system and drive the need for prior authorization, he has also seen how administrative barriers created by prior authorization can burden health systems and lead to delays in care, especially for complex cases that require coordination of health services across multiple specialties.
It's like a house of cards because you're talking about somebody that's going to probably 8 providers at once because you have nutrition, you have physical therapy, occupational therapy. Almost everybody's in mental health at that time. You have a surgeon, a medical oncologist, a radiation oncologist, an outpatient infusion center, and a hospital. Coordinated multidisciplinary care has better outcomes. And unless you are with an entity that's large enough to go ahead and provide all the care, realizing they're going to be paid later, one link breaks and you have a really tough time giving the care. When I was at the Children's Hospital here, I have no idea if they got prior authorization, but I can tell you that I never ever had a case booking delayed. And it's a little different because in California, every child has some form of health insurance. And so there is some sort of implied guarantee that there will be some payment. And I'm unfamiliar with the deep down workings, but they obviously have decided that they are not going to delay care because either they can float it, they know they're going to get paid at some point, but these are the economic 900-pound gorillas. And the next echelon below that, they are not willing to take any chances on not getting paid. And I think it's because I think many hospitals now are operating on very, very thin profit margins, and they can't afford an expensive hospitalization that doesn't get paid for.
It's clear that prior authorization creates barriers to care that we must overcome. I asked Dr. Hammel what he would do about it. What follows is his actual proposal, an audit-based system where doctors who consistently follow evidence-based guidelines are exempted from utilization review entirely.
I do have a solution, and that's to, you're on these plan policies and you can invite them into your records to audit your utilization practices. And if they go through and they say Dr. Joy is following plan policy guidelines 97% of the time, Dr. Joy gets a gold star and she no longer has to participate in utilization review because she's been decided that she's following evidence-based treatment guidelines. I mean, that saves so much time and money that the amount of extra work and care you could provide, the frustration level goes down. Your patients feel the benefits and that their care is accelerated. They never get a denial. And then maybe the insurance company visits with you once every 5 years and says, let us see 75 charts. And they say, look, Dr. Joy's still a gold star. I mean, the opposite's true too. They could visit Dr. Sadness's office and find out that Dr. Sadness is only 40% in compliance with the plan policy guidelines. And they say, you know what, we're going to remediate Dr. Sadness because they obviously need education. And then they'll go to Dr. Evil's office and find that Dr. Evil is in compliance with plan policy guideline evidence-based treatment practices 3% of the time. And Dr. Evil will just be excluded from that policy in perpetuity, and that person is a bad actor, and they will probably just be, it will be found that they'll be thrown off all of these plans. And eventually, hopefully you can get everybody to be a gold star and the whole utilization review industry can go away. This is a multi-$100 billion industry. We know that it's something insane, like 33 cents of every healthcare dollar is spent on administrative costs. And I would say utilization review, it's almost impossible for me to give you a number, but there's not a chance it's less than $100 billion a year. And that could be redistributed then to Dr. Joy. Dr. Joy could actually get paid a little bit more because she's not using that utilization resource for her patients. And that's without tracking patient outcomes. You could then have a second layer where you then say, okay, Dr. Sadness has been brought up to Dr. Joy's level in terms of compliance with evidence-based treatment guidelines. Now who's getting better outcomes? And you can incentivize those providers financially, and then they can expand their practices and treat more people in the most cost-effective way that leads to the best outcome measures. So there's a bright star solution for this. It's just a somebody has to tackle it. I mean, if you work at the VA, you have an automatic gold star, but that's because your incentive is aligned with the business. There is no financial incentive to do a test or do a procedure. Admittedly, there's no incentive to improve a healthcare outcome either, but the removal of the financial incentive misalignment obviates the need for utilization review. Because if I'm not getting paid extra to do a thing, they know I'm not going to do it unless it's needed. And so, my federalized practice in the military, there is no utilization review. You just schedule your surgeries. If you needed it, you just pull the injection out of the cabinet and give it. I mean, these are things that cost $1,000 a vial, these visco supplement injections for knee arthritis. We just had a cabinet full of them. And I didn't use them when they weren't indicated because I had no reason to.
I think your argument makes sense when we're talking about physicians being compensated directly for services that they may be overbilling or performing when it's not medically indicated because they're financially incented to do that. But I would tell you that most of the challenges that our practice faces in primary care with prior authorization and services being denied really are pertaining to things that have no impact on us financially. They're things that we're ordering for our patients, like medications, like imaging studies, like labs. So we aren't incented in any way to order those things from a financial gain standpoint. The only incentive is we're trying to get answers to help our patient in some way.
Yeah.
And so it's incredibly frustrating.
Some practices, though, are, right? I own my own x-ray machine, and we owned an MRI. And so these things are allowed and they're frequently done, and there are many pain management practices that dispense medication like a pharmacy. And I would tell you from my experience in utilization review, I know for sure that there are occupational medicine and primary care physicians that also dispense medications, who dispense DME. And so again, I think that there's a bell curve of virtue. Unfortunately, I think there are some physicians that are behaving badly, and it only takes a couple and the whole industry gets locked up.
I hear what you're saying. There's the minority of doctors out there that are financially driven and abusing the system, but I do think that the story is a little more complex than that. For example, just the cost of things, right? We have price fixing on the cost of medications. We have price fixing on the cost of technology, like MRIs, for example. Who's to say that maybe you could do an MRI for the same cost as an X-ray? Maybe there's new technology that comes out, a new MRI machine that's really inexpensive to operate and can be done with very little skill. I think that from a utilization management perspective, the knee-jerk answer is always, let's do less care. Let's do less procedures. Let's do less testing because that will save money. My thought process is as our society becomes more technologically capable at a lower cost, we're still paying a premium for procedures that with normal market dynamics that were not interfered with by price fixing, you would hope the cost of things would come down, not go up.
No, and I agree with you. And I think that we are entering a time right this minute in the last year where the actual utilization of consumer cash pay fee for service has gone up. I mean, it's got to have gone up 4 or 5 times in the last couple of years. Someone in my family had an MRI last week, which I think if you asked somebody on the street what they thought the test cost, they would say close to $2,000. But they don't know I'm a physician. When I called, we just called the office, $230 for a lumbar spine MRI. I think that's shockingly low, but I think as an MRI provider recently, it tracks exactly, 5 years ago, we were getting paid maybe $330 from Medicare for that test. And so I think that these costs in truth are way, way lower than people perceive, and that the people that own these devices want to get out into mainstream knowledge. But because everything's getting so difficult with insurance, you're seeing patients that are gladly paying cash either for getting the study done quickly or because it's been denied by insurance. And to your point about better care through the use of studies, I mean, for sure, this is well known in specific areas through medicine. There's a specific wrist fracture, one of the bones in the wrist that can break, and it's notorious for kind of not showing up on x-ray. And the old school treatment was, we'll put you in a cast and we'll bring you back every 10 days or 2 weeks and get a new x-ray. And so you end up with 3 cast applications, 3 or 4 office visits, 3 or 4 sets of x-rays. Now you have work absenteeism for 4 hours at a time, right? Because you have to come in, get a cast cut off, get an x-ray, wait for the doctor, get put back in a cast. So they did a cost benefit analysis. This study was published in maybe 2008, and it's way cheaper. And they used a $700 MRI price at the time to just take that person and get them a wrist MRI on the same day. And if it's broken, treat them. And if it's not broken, give them a Velcro wrist splint and send them back to work. It makes perfect sense. But again, there's a reason why somebody designing the system wants to limit access to the use of MRI for this condition. I guess to some degree as physicians, it's our responsibility to highlight cases like this. But I'll tell you, that's been out there for 15 years, and I still can't get an acute wrist MRI approved.
And there's a lot of other examples I could give you in the primary care setting that we deal with that are exactly the same. We're good enough diagnosticians that we know when somebody likely has a specific condition and we want to get the definitive test. We don't want to go through the hoops. We don't want to do all the the physical therapy and the waiting and the return visits and the rechecks, right? Like you're trying to give the best care to the patient that's in front of you, and you know what the patient probably has and you've communicated that to them, but then you're basically giving them this caveat like, well, it's probably this, but the insurance company won't let us get the MRI until you go through all these hoops. And they're like, well, that's ridiculous. And so that's why people do go end up paying cash. But I do think it's self-defeating to some extent, like you just explained, because there's some short-sightedness, as you just highlighted, that there are other costs. I mean, if you look at just the cost of the MRI, that's one thing. But if you're looking at the total cost of care, which includes all of those rechecks and the time lost and all of that kind of stuff, and even the cost of physical therapy is not insignificant. If somebody has to go 2 times a week for PT for 6 weeks, that's not an insignificant cost either. And so coming up with a clinical treatment pathway that requires certain things before other things get done may not always be cost effective.
No, I agree with you completely. To benchmark it, again, we own and operate a physical therapy location for our post-surgical patients. We get paid, I think we get like $235 from Medicare for a new patient assessment. That's an hour-long visit. So the MRI I just told you about is actually less expensive than the initial evaluation from a physical therapist. From an insurance standpoint, I know what they're worried about. They're worried about an abnormal finding on an MRI trying to be used for justification for an invasive procedure, and this comes down to the fundamental nature of insurance companies as a publicly traded company, right? It is by mandate that their primary responsibility is to their shareholder. They are required by law to deliver for their shareholders before they deliver for their customers. So that's a problem. I'm not sure how you rectify that problem while you still have publicly traded for-profit insurance companies, but it's pretty glaring. We would call it a conflict of interest in medicine. Somehow it's not for them. I don't know.
Yeah, I hear you. This is what I was getting at when I was saying earlier that it's a tough pill to swallow to say that it's all just doctors abusing the system and doing too many unnecessary procedures, because there is a perverse incentive there to keep the cost of care as low as possible. And also to pass the buck too. I think an insurance company is looking at how does that affect my profit margin this year, not a longitudinal perspective, like how is this patient going to do long-term, say 5-10 years from now? And how do the decisions that we make around what we cover in terms of their health services now impact what happens to them 10 years from now? Because 10 years from now, that patient's either on Medicare or they've switched to a new plan. And so there isn't this incentive to have that longitudinal perspective for your cohort.
You'll only get that if you can guarantee somebody sticks with the same insurance company for 20 years. You get it automatically in a national health service, right? Because there is only one insurance and they own you the whole way. And, I think there is an incentive in a national health service could incentivize its providers financially. I just wouldn't recommend they incentivize them to do procedures. I think should incentivize them to be available to see patients. And they could incentivize their providers for, health outcome measures. And I've, been listening to your podcast. And so, real health outcome measures like my LDL went down, not I was compliant with medical therapy. I like to start these discussions by saying, maybe we could all agree on this, is that if you could guarantee that the patients in the insurance pool at age 22 were going to be in the same insurance pool at age 82, that would eliminate the concern of insurance switching, which we see all the time. I see somebody that sees me in January, they were in Kaiser, they couldn't get their knee replaced, they just want to get their knee replaced, now they have Blue Cross, and then they're going to go right back to Kaiser. And I tell them, well, you're letting Kaiser win. You let them string you along forever. You switch insurance to a more expensive, more permissive plan. You get your expensive procedure done. It's a moment in time procedure that restores your function. And then you go back to Kaiser better, and they collect your insurance premium again. So obviously Kaiser's winning the casino game there. So, I think I'm laying the groundwork for a single payer system with a boutique cash pay, true free market sort of option on the side. And that would be one way I would intro it, is to say, in whatever inherent conflict you can identify in our current system, I can describe at least the possibility of a system that eliminates that concern under the framework of a single payer, not for profit, properly incentivized alignment system.
I think there's definitely an argument to be had with respect to what you're proposing. I think the devil's in the details, right?
That's where this discussion of how do you incentivize physicians comes from, because there's a lot in here. Like, what's the societal value of a physician versus other specialties, right? Because we have data, right? The VA salaries for internal medicine this year range, depending on where you are in the country and how senior you are, $123,000 a year to $315,000 a year. Emergency medicine, $123,000 to $400,000. Orthopedic surgery has that same range. And then government statistics for the average 2025 salaries: supermarket manager, $65,000, accountant, $75,000, airline pilot, $200,000. And so let's just say that because these are the averages, if we just assume that those are fair, balanced salary ranges that society can agree on, these are the relative values of these professions amongst society. How do you get to the top end? How can you incentivize your physicians to do better? I mean, you would tell me, but how to incentivize emergency medicine physicians to provide good medicine without necessarily incentivizing them to over or underutilize resources. I can tell you from an orthopedic standpoint, I'm going to incentivize my orthopedic surgeons for being available in the office, because if they're available in the office, they're going to provide a lot more meaningful non-surgical care. And then the way it works in the VA is, if the VA gets backed up, they just look ahead and they switch their physician schedules to be more operating room heavy to get through their backloads. And so, you don't incentivize your orthopedic surgeons to do surgery. You don't incentivize them not to. And you realize that if I double my office-based load of patients, I'm probably going to double my OR utilization, but I'm not going to disproportionately do surgeries. I'm going to do surgery only when it's needed.
Yeah, I think that's a really good point that you're highlighting, which is that every specialty has its own unique culture and requirements and the things that are motivational to them versus disincentivizing to them. And so it's not a one size fits all. You can't necessarily incentivize primary care the same way you would orthopedic surgery, because we do very different functions. But I do think that there has to be a little bit of caution around incentivizing people based on savings to the health system, because there can be the flip side of that coin, right?
I agree with you completely. That isn't part of my plan at all. And I do know for a fact that there is a large health insurance subsidized multi-specialty group in this town where the primary care physicians are incentivized for low use of MRI. And that's exactly what you're talking about. That is completely misaligned. It's 100% in line for profit taking and 100% misaligned for patient outcomes. And it's done in a way that's invisible to patients, and it may even be invisible to regulatory bodies. I'm not sure. I don't even know if such a thing is legal or not. I imagine it's legal, because I just assume these companies wouldn't be intentionally breaking the law, and they wouldn't have a mechanism for cutting a check without a rationalized target that's written down somewhere. But I think it happens all the time, and primary care has borne the brunt of reimbursement discrepancy over time, and subspecialties, especially procedural subspecialties like mine, are the most protected. over the last 20 years from the financial fallout of decreasing reimbursements. And I guess that's where I have a bit of a cynical view to some degree, as I've watched my colleagues, both through my practice and through my utilization review, I've watched them respond to decreasing reimbursements with increased utilization rates of invasive procedures. I know it to be wrong. I know it to be unethical. It's legal, but I don't think it's the way that you solve your business problems. At the end of the day, everything we talk about when there's a failure of the healthcare system, the person that suffers is the patient. It's never the insurance company. It's really not the physician. We can complain about reimbursement rates. We can complain about staying late and charting. I mean, these are all things that if we really didn't like them, we would change what we're doing, which is sort of what I did eventually. But we don't suffer. Patients suffer.
Yeah, definitely patients suffer. And if you're a physician that works for a large health system and you're collecting your salary and then your bonus payment at the end of the year, someone else is solving those business problems for you and telling you what to do, basically. Here's the mark that you need to hit, and then you're going to get paid X. I think it's a little different when you're in solo practice or true private practice where you're really running the business and you're operating on slim margins, you're having the pressure of increased cost of labor and inflation, everything is going up and Medicare reimbursements going down. And it's hard to make a living, and even to meet those salaries that you just mentioned, it's hard to achieve that without the support of the large health system, because most health systems look at primary care, for example, as a loss leader and a feeder into their more expensive procedures, which then allows them to pay more competitive salaries back to their primary care physicians because they're basically robbing Peter to pay Paul kind of a thing. But primary care itself isn't really, it's not really compensated what its true value is on a fee-for-service basis.
Right. And also in the setup you described, you literally have the hospital system trying to increase their pool of primary care providers to drive. I know for sure that you'll get thrown out of an interview if you start to talk about downstream revenue, which is how much studies can I order you? The hospital systems are building farms of primary care providers to try and drive increased utilization of testing and procedures. And insurance companies are then therefore doing what? They are enacting these barriers to the utilization of testing and procedures. And like we were covering before with tumor care, if you're a small business, it's incredibly detrimental. And if you're a hospital or a hospital system or a 800 physician multi-specialty group, it's not as damaging because you have the economy of scale to, I don't get paid for 9 months because of the disputes or whatever, but I'm in a true private practice. I know you are. Just some data to share, I think, to frame this for listeners, because I think in general, physicians complaining about reimbursement is like the world's smallest violin. But to break things
I
down
hear you.
into, again, like I say, I like to start discussions or debates. If we can start from a kernel of truth that we can both agree on, then we can kind of grow from there and we can grow together rather than apart. Is that this is one of the only industries around where functionally the government sets our revenues, right? So they set Medicare prices. The insurance companies lock step with Medicare, usually on a multiplier basis. They say, we'll pay 125% of Medicare fees. Usually, when an industry's revenues are regulated by the government, they either have subsidies, and this industry does have some subsidies. Unfortunately, it's exclusively captured by residency training facilities, or they get protected on their cost side. And so since 1999, when the Congress saw that the healthcare spending was going to spiral out of control, they enacted this annual reduction in Medicare reimbursement rates that some years it gets voted on not to do it to us. Some years they let it happen, and some years they let it happen and let a couple extra years that had been previously postponed happen all at once. Is that since 1999, the nominal decrease in Medicare fees across the board on average is down 7%. Inflation adjusted, that means it's down more than one third. But the cost of a medical assistant or an x-ray technologist has gone up 100%. Medical office space has gone up 50%. Utilities have gone up 100%. The cost of our portions, as the owner of the business, what I pay for my employees' health insurance premium over the same time frame has gone up 500%. That's the real kicker. So, I use this argument when I'm talking to people is that we use Blue Shield at my office, and every year we get an 11 or a 12% rate increase. At the same time, we get a notification that we're getting a decrease in reimbursements for Blue Shield. So they're selling us back the service that we provide for more, and they're reimbursing us less. And the example I think that really would broadly resonate with people would be if we were a brand new country and we were growing tobacco down on the East Coast and we were sending it back to Great Britain at a fixed price, and then they would make cigars and sell the cigars back to the colonies. It'd be like if they kept raising the price of the cigars but decreasing what they were going to pay us for the tobacco. We're like, we are literally making the cigars for you and you're gouging us. So private practice medicine feels like colonialism right now because we're providing the product. We get reimbursed less for it every year. Yet when we pay for the product for our employees, we're paying more. So it's completely unsustainable. And I think these numbers are important for people that don't practice medicine to know, because my patients will ask, what do you get paid for this surgery? I am happy to tell them that in 1999, Medicare would pay me $1,700 to do the knee replacement and take care of them for 90 days after surgery. Now they'll pay $1,200. So that's down almost a third in actual dollars, where the hospitals has seen an increase of 130% over the same amount of time. So the hospitals, I don't know how they manage it, but they've managed to negotiate increased rates from Medicare. And over time, all I can think is that the people with the most money to lobby the government have decided that they want private practice physicians out of business. And I just don't see another reason why this is how it goes other than they want these industries and these corporations to be able to consolidate the workforce for the same reasons we talked about, is then you can price fix and wage fix.
So when you're quoting those numbers, that's not adjusted for inflation. Those are actual
Those are
dollars.
actual dollars. And so it's way worse when you consider inflation. Here's a good corollary. Since 1999 compared to today, the consumer price index, right? So this is a washing machine. It's everything that's non-utilities and like gasoline or something like that. That's up 100%. So that same $1,700 in purchasing power in 1999, that's $3,400 today. So, if they just paid me the same as they paid me adjusted for inflation in 1999, they'd be paying me 3 times what they're paying me today. And this trend gets worse the further you look back. So it's really, I popped this in because I can talk to people that used to get paid for a knee replacement in the 70s. 1974 reimbursements for a knee replacement pushed through with inflation today. The number, and again, this is not what I think an orthopedic surgeon deserves to be paid for a knee replacement, but the number is $44,000. If I go around and say that that's what I think I should be paid, first of all, that's ridiculous. And second of all, no one will listen to me. It just is to highlight that the trend is moving in an unsustainable direction with reimbursements going down, rent, utilities going up, employment costs going up, and then the real insult to injury being the cost to insure my employees quintupling. That's why I am working less in that field, is because even as a subspecialist, and again, I'm not complaining because this is a good living and it's a rewarding field, but it's so challenging to run the business as a small business owner that to me, it's not worth the time. And again, reflecting back on my time in a federalized practice, it was not perfect. But one of the things I never struggled with was the running of the business other than personnel. If you had someone that was not doing a good job in one of your supportive roles, then you had to address that. But you didn't have any of this other stuff. So I worked at the Naval Medical Center. And, what's really funny is that it's so nuanced because there's an arm of insurance for military beneficiaries that is called TRICARE, and it's a commercial insurance plan that's funded by the government. Think of it like a Medicare, but it's just a specialty just for military members and their families as well as retirees. Because it comes out of a different budget center, there's a region that is the insurance, TRICARE West, covers the whole West Coast, and they're in charge of spending, and they have to interact with privatized physician groups and hospitals. And so it's almost indistinguishable from Blue Cross. And then there is the Navy Medical Center, which has a budget. And if we were spending more than they thought we should spend based on last year's projections, you would see certain categories of beneficiaries. They'd say, well, we're not going to see spouses anymore at the hospital. We're going to let those go out of network. And I would always say, but we're here and we're underutilized. I have clinic time open. Why wouldn't we see these people? And the administrators would say, well, that's a different bucket of money. And so the alignment was wrong again, where the administrators of the Navy Medical Center were incentivized to have a good looking budget rather than provide inexpensive care. So instead of providing free, right, because I'm already paid to be there, I'm salaried. Instead of providing free healthcare for a beneficiary, they would rather them go to a fee-for-service provider in the community because it came out of a different budget. And I bring that up just because that's sort of like a half measure on a fully single-payer public option, right? Because you're just sort of shunting the problem to a different cost center. But if my time seeing patients, that was fantastic. And unfortunately, I think I didn't realize how good that was until I left, and that you never had to worry about a prior authorization. I think you deal with this in primary care quite a bit, is drug tiers. So you want to prescribe a drug, and they say, well, you need to use tier 1 first. Not a concern in the single payer system because they know that I'm going to cost contain automatically based on what I think the appropriate drug is. And then also, if you're the biggest buyer of a tier 3 drug as the United States government and you feel like you're paying too much, you can just decide to pay less. Right? Or you could run into a position that's totally real. I think I told you about the viscose supplement injections for knee arthritis, is that eventually there was a cost concern. And so I actually got on a committee where they had a bunch of orthopedic surgeons come on and said, we have to narrow the formulary. We're not getting preferred vendor pricing because we're spreading our purchasing power out among multiple vendors. And so we got together and we decided we want to have 2 single shot varieties available and 2 multi-shot varieties available, but we don't need access to 25 different kinds. And that allowed the payer to do a huge volume discount and still give the providers flexibility amongst single shot versus multi-shot. And then even amongst those have an A/B choice where somebody says, well, this one doesn't work as well for me. So we have some flexibility to go. So I think you do lose some flexibility on pharmacy. I think we had trouble getting our patients into therapy for therapy clinics being full and resistance to hiring to sort of fill that need. But those are struggles that don't go away. We have those in private practice. When do you hire a new physician? Like when we're all booked up completely, when we're booked out a week, when we're booked out 3 weeks, when can your practice afford to hire a new physician? That doesn't go away at a government level, but I don't think I experienced it as acutely as I do.
Well, and just the management of it all didn't fall on your shoulders at the end of the day, right? I
Right.
mean, that's the other aspect of it.
Yeah, for better
Someone
or
else.
worse, because we could
Yeah.
complain for months about being understaffed, and you would get the feeling that they didn't care about you, but then you also didn't have to deal with hiring anybody. And you would know as a business owner, the worst possible thing you can do is to hire a provider that leaves in the first 2 years. The most stressful thing we do as private practice physicians is hire a new physician.
Right, because then you're supporting their salary while they're building out their practice.
And then if they leave, you're out 6 figures.
Yeah, exactly. Yeah, it works at economies of scale. It doesn't work very well when you're a group of like 5 to 10 docs.
Yeah. And I was talking to somebody who works for a multi-hundred physician, multi-specialty group. They get paid well. And I said, just remember that when the consolidation reaches a specific level, and you can look at this through private equity acquisitions through multiple arenas. I think anybody that has a pet is aware that their veterinary bill is much higher than it was 6 years ago or 8 years ago, like double or double and a half. But that's because private equity achieved like a 70+% penetration in the market for acquisition of veterinary practices. And then as soon as they do that, they price fix. And then the other thing they do is that they wage fix. And if you go back and you look, people that work at the veterinary offices on average make less money now than they did 8 years ago, and the consumers are paying double and a half what they're paying. And so I just said, be careful. If you see your system consolidate with the other system, not only do you start to lose autonomy of scheduling, but I think that at a certain point, the tides will turn in a nefarious way, and you probably won't see wage reduction, but you'll see wage stagnation.
I mean, one could make the argument that in a single payer system, you're going to see that too, right?
You could, but I think What we don't account for is, and the government being inefficient, sure, I get it, but how inefficient is utilization review? How inefficient is
Oh, totally.
like who's paying for these corporate skyscrapers? These are owned by these companies, and they say Blue Cross on the side, they say Fresney on the side, they say DaVita, the dialysis industry. Look at the dialysis industry. It's just two players. Every independent clinic was rolled up by private equity. Outcomes are worse, expenses up, satisfaction of the people that work in those centers is down. It should be a very concerning predicate for what it looks like when you get hyper consolidation. And that was essentially a very true private practice model that was ripe for the pickings. And I don't think hospitals really run outpatient dialysis units. They provide dialysis to inpatients, but they don't run outpatient dialysis units as a rule. And so that got lost. I don't think you can find a nephrologist that's excited about a dialysis center. But, in general, I think consolidation, again, my timeline's always 1999 to 2025. Private practice was 70% of physicians. Now it's 40, a 45% decline. Employed physicians, and that's hospital employed, insurance company employed, that's gone from 30% of physicians to 60%, doubled, up 100%. And the worrisome thing is that 70% is your magic number. That's when you start to see market forces by these are business people that are at the very tops of these food chains. At 70% market penetrance, that's a functional monopoly, and you end up with the same thing. You end up with a single provider. I mean, we're functionally a single payer system. I mean, the government's the single largest payer, right?
Yeah. The other thing that's sort of on the periphery of the entire conversation that we've been having, as I kind of take a step back and look at it all, is that there's this inherent uncoupling of the consumer from having to actually pay for the service. In a normal market, you have consumers that are incented in different ways. They're the ones that are deciding to pay for a service or not pay for a service. And healthcare is unique in that, right? Like that the consumer is essentially completely uncoupled from the decision to pay for something or even the knowledge of what something costs. They do to some extent have copays and things, but they're so nominal that I don't think it really influences their behavior patterns. And so in a way, it's disenfranchising people in the system, and large companies are making decisions on where people go for their care and what kind of care they're going to get. I think it's hard though, because how do you give the power back to the consumer when people can't afford to pay for the services that they need, right?
Well, I agree with you completely, and I think we're at the verge of an exciting time. Like I was saying, is I have a lot of patients that just don't want to deal with insurance anymore, and not everybody's in a position to do this, but if you're in a position to do it and you don't want to wait for MRI, and the MRI price has come down and is $230, that's going to eventually drive the market away from these high premium plans. Lots of people talk about the employer-sponsored healthcare plans as being the beginning of the end for price transparency, and that's something from I think it's from the 60s or 70s. But me personally, for my family of four, I think my monthly premium is like $4,000 a month. And if you're my employee and I pay 90% of your premium, you might think it's a relative bargain at $385 a month, or maybe I pay 80% and you pay $700 a month or something. And so it might seem like a relative bargain, but it comes out of somewhere. And so I'm acutely aware of the imbalance between what I receive in benefits, even at sticker rates, right? Not negotiated best pay cash pay rates, between what I utilize and what I pay. And next year, I'm going to have a different plan. I'm choosing a high deductible, catastrophic coverage only through Kaiser, a Kaiser HMO plan that the ER is free, but the hospital stay has a $15,000 deductible, because I know that I'm paying almost $50,000 a year in premium. And unless all four of my family members end up with a hospital stay, I'm going to come out slightly behind if all four of us wind up in the hospital. But otherwise, I'm going to come out ahead. And I think we're in the dawn of when it's going to start to become more commonplace. I'm optimistic for price transparency. I just hope it catches on, because people will do better when they can see what it's going to cost them ahead of time. They will automatically select more efficient venues of care. I know that's another thing that you've covered a lot, is that the venue of care really matters. And if you knew in advance, well, I'm not going to die from this, and I can see my primary care physician and get an outpatient imaging study and get some labs done, and it's going to cost me $500, or I can go to the emergency room and it's going to cost me $15,000, you're going to choose the cheaper one if it's available. And if the wheels come off and you're doing very poorly in the middle of that, you're just going to pivot and go to the emergency room. And that's actually how it should be.
Yeah, I mean, I think that there's an opportunity for innovation in the insurance industry in general. And maybe insurance is the wrong name for the product itself, because insurance implies a sick care model. I mean, what you just described, a catastrophic policy, that's really what insurance is designed for, is when
Right.
something really goes sideways, versus how do you keep routine care accessible and affordable and high quality. And that's one area that I'm really interested in, is like, how do we innovate in that space? And maybe it's a product that's not insurance, it's something else like memberships or direct primary care that I think are underutilized, but in the market dynamics we're dealing with now might become a better option for people.
Yeah, especially if you could. I mean, I think one of the solutions might be to try and uncouple catastrophic care from healthcare, right? And so, I think in general, people don't do a good job budgeting for future expenses. I think that's one of the reasons employer-sponsored healthcare plans were attractive. I can tell you for sure from my end is that at the end of the year, when people's deductibles have been met, they come like gangbusters to the office. Everybody wants their expensive procedure done in November or December, because otherwise, they're going to have to cough up $7,500, $12,000 in January. So it's like a race. My operating room schedule would fill in August for Thanksgiving and beyond. Everybody wants the same surgery date. And I think a FSA is actually a really good instrument for this, or an HSA. I think some sort of coupling of a catastrophic, as low as premium can be, catastrophic. I think in other countries, they call the emergency department accident and injury. Unplanned hospital care should be different than healthcare. And you want to see how low you can reduce the price of unintentional hospitalized care. And everything else, I think you can manage much better in a smaller portfolio with a flexible spending account or a healthcare savings account. Maybe instead of paying $3,000 a month for my employees, I could give them, $36,000 in a flexible spending account for healthcare, for glasses, for contacts, for podiatry visits, for orthotics, for their elective knee arthroscopy that costs, total cost outpatients probably like $4,500. So it's not like it breaks the bank. I think that's a great idea. And then there's meat on the bone for re-incentivizing primary care physicians to drive positive health outcomes. Like there are so many creative ways to do it. And, I think if we don't see a creative solution, I think the de facto solution is going to end up be just taking the private insurance companies public and making a Medicare for all, and deciding that Blue Cross will just be the Medicare administrator, and they'll have a government auditor in there, and it'll cap their profit margin, and it won't feel much different. It'll probably feel more clunky, and I don't think anybody's going to be more happy with it, but it'll cost less money. But innovation in the way we're talking about may make people excited to practice medicine again, and it may align the incentives better for health maintenance versus real accident and injury.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare through conversation. If you liked what you heard today, please follow this podcast and share it with your family, friends, and colleagues. By spreading awareness, we can bring about change. You can also connect with me on Instagram at Dr. Joy MD. That's DOCTOR Joy MD.